Hello, welcome. My name's Neil Dilworth, and today we're going to be going over the primary care conditions of the knee from a sports medicine perspective. So let's get started. From a disclosure perspective, I have no financial or commercial interests. This is a complete free endeavor for educational purposes. When we think of differentials of the knee, there's quite a significant number of things that can cause discomfort or issues within the knee, and there's a number of ways of breaking down those differentials. You can break it down into several categories, from tendon and muscle to bone and ligament and other conditions, and you can see there's a number of things affecting each one of those categories. The other thing that you can take a look at is the different areas of the knee from an anatomical location, so taking a look at things that cause pain at the front of the knee, back of the knee, inside and outside of the knee, so anterior, posterior, lateral, medial. And that's very helpful, especially when a patient's describing their symptoms to you over time. There's some very important things from a knee consideration that should be included in every assessment. One of the first things to talk about is range of motion. So obviously the knee main function is extension and flexion, and one of the things we want to make sure is that there's not a loss of flexion or extension. Loss of flexion can indicate essentially interarticular pathology, anything from a meniscal tear to an osteochondral defect to osteoarthritis, whereas loss of extension could also mean osteoarthritis, but it could also mean that the joint itself is locked as a result of something blocking the joint from extension, such as a loose body, flipped anterior cruciate ligament, or a bucket-handed meniscal tear. The second component of the range of motion is actually looking at the patellofemoral joint and how the patella slides both and glides both proximally and distally over the trochlea, but also as well laterally over the trochlea. We always want to ensure that the extensor mechanism is intact, so that's making sure that the patient can conduct a straight leg raise, as well as extend the knee from flexion. We also want to make sure that the knee is stable by conducting both a ligamentous examination and meniscus. You take a look at Dr. Wynn's lecture, he goes into that in further detail. And we also always want to check for warmth and whether or not there's a swelling within the joint, and not just superficially. The swelling from within the joint as a joint effusion is an indication that there's a problem interarticularly. And then finally, with any sports medicine and orthopedic examination, we want to make sure that we complete the examination with a neurovascular status of the area below the joint, and that includes the color of the joint. This is an interesting study done back in 1998, which is extremely helpful. This was essentially an awake arthroscopy done on a physician by an orthopedic surgeon, and what they did was they essentially, instead of using sedation or a general anesthetic, they just put local anesthetic into the skin portal sites, and then once in the joint with the scope, they used essentially a pressure gauge and pushed on the different tissues, and then asked the patient, which was a physician in this case, whether or not they could determine where the area was being pressed and how painful it was. Now you'll see two images. One is essentially a open anterior view of a flexed knee, that's categorized by A, and then you see a lateral or sagittal view of the knee, B. Then you'll see the letter A and B being used next to numbers. The numbers indicate anything from 0 being no sensation or no pain to 4 being severe pain, and then the letter A next to the number indicates that the patient was very able to localize that pain sensation, whereas B is they were able to detect pain, but it was poorly localized. What's most interesting about this is that by far and away the most sensitive tissue is the fat pad, hoffa's fat pad, which lies underneath the patella as well as in between the patella and the trochlea, and can be contiguous with the ligamentous mucosum. The next most tender tissues are the most proximal and most distal segments of the anterior cruciate ligament. And interestingly enough, where the ACL or the anterior cruciate ligament is commonly torn in the mid portion, it's a lot less sensitive, but also it doesn't localize as well. And that goes as well with the meniscus. So you can see that a lateral meniscus is more sensitive to palpation than the medial meniscus, but both localize fairly poorly. And this is very helpful, especially for those of you who have had essentially knee pain and had difficulty localizing yourself as either a resident or a sports physician or a family doctor. This gives us a much better insight as to why it's difficult for patients to describe. The final thing, a piece of tissue that I will point out is that the suprapatellar bursa is also very, very tender above the knee. And that's something that can get irritated, obviously, with prolonged lunging, squatting activities. Next thing we want to take a look at are knee radiographs. This is something that's going to be very common that we're going to be taking a look at in sports medicine practice. And typically in our practice, the views that we will order are an AP of the knee, a weight-bearing view of the knee to assess the medial and lateral joint spaces, a lateral of the knee tunnel views, which are very helpful for taking a look at the medial and lateral condyles, also known as a notch view, and very helpful for taking a look at things like osteochondritis dissecans, a skyline, which is essentially a view specifically of the patellofemoral joint with the knee flexed about 30 to 45 degrees and the x-ray shot through. And finally, an oblique. Oblique is more of a trauma set that we typically see in the hospital setting, in an emergency department, or that orthopedic surgeons will order, but it can also be helpful from a sports medicine perspective to take a look at both osteochondral defects of the condyles of the femur, as well as impaction fractures that can be associated with ACL tears. So the first condition we're going to talk about is patellofemoral pain syndrome, which isn't without controversy in terms of the name, also known as contrarrelation of the patella, anterior knee pain, which is probably a more accurate description. Patellar maltracking and runner's knee are also other terms that are commonly used. There's in fact very little evidence to support either the maltracking or the contrarrelation. There's many potential causes, and as we saw in that awake arthroscopy study, there are obviously a large amount of tissue, such as the fat pad and ligaments and mucosa, which can cause pain anteriorly. There's often no injury, but sometimes patients will report increased incidence of lunging, squatting, running, and that will predispose them to the pain. Differential of that kind of anterior knee pain, so once again we consider all the tissues involved there, so patellar tendon, quad tendon, the fat pad, anterior meniscus, the bursal tissue, both above the knee, in front of the knee, as well as in front of and behind the patellar tendon. These are all things that can essentially cause anterior knee pain. In a younger patient, we want to consider Sinding-Larsen-Johansson, which is an apophysitis of the patellar tendon, or an Osgood-Schlatter, an apophysitis of the tibial tuberosity, and in older patients or patients with a history of trauma to the knee, osteoarthritis of the patellofemoral joint. On examination, there can be effusion, but it's actually very rare. And when you do see an effusion with somebody with patellofemoral pain or anterior knee pain, you want to make sure that you do a full examination, like we talked about before, to make sure that you're not missing any other injury with respect to the meniscal or ligamentous injury. Specifically with patellofemoral pain, the pain can be reproduced with single leg squats, patellofemoral grind, which is essentially pushing downward on the patella into the trochlea. The other thing that you can see sometimes is with dynamic testing is when you have a patient jump forward on a single leg squat, you'll see their knee, so if it was a right knee, they'll see the right knee collapse in an valgus position on the affected side, and that's an indication that the glutes aren't firing as well on that side. This is mainly a clinical diagnosis. Sometimes we will do imaging either with prolonged symptoms or a patient fails to progress with physiotherapy and modifications. We can take a look at x-rays to rule out osteoarthritis and osteochondral defects, as well as MRIs for other pathologies such as like a plica. Management, mainly modification of the aggravating activities, whether it's squatting or running, switching to low impact activities in the interim. Physiotherapy from the rehabilitation perspective, focusing on that glute strengthening and quad strengthening, as well as potential gait modifications. There's some Some evidence to suggest that shortening of the stride and quickening the pace can actually decrease patellofemoral pain and running. Patellofemoral instability, so this is one of the big things in terms of to be aware of and to make sure that you identify as different from the previous entity of patellofemoral pain. Yes, it will cause quote-unquote patellofemoral pain, but it's a different mechanism. So there's two versions essentially. One is an inherent laxity where the patient has ligamentous laxity, you typically in more than just the one ligament, and they will have spontaneous or the kneecap will essentially either pop out or shift outwards very easily with minimal activity. The second version is obviously either the initial incident, which was a traumatic injury to blow to the patella, causing it to dislocate the sublux and injuring the medial patellofemoral ligament, and that can cause subsequent essentially instability in the knee. This is something whereby this is more in keeping with maltracking in the sense that you're going to have a lot more lateral movement than you normally would while doing squatting or lunging activities on the knee. Acutely with a traumatic patellofemoral dislocation, it's very, very difficult to differentiate between that and an ACL tear. And so I often will have patients with an acute swollen knee come back in 1 to 2 weeks so we can reassess once the swelling's come down and the pain levels come down. Osteochondral defect is another thing we have to be aware of here. It's associated with patellofemoral dislocation, and it can also occur as a result of repetitive either dislocations or subluxations. Obviously, patellofemoral pain or anterior knee pain can happen with this. Typically, once again, there's not a swelling or effusion of the joint with it. And then finally, Plica Syndrome, which is an embryological remnant of connective tissue over top of the femoral condyles. That can also get inflamed and cause pain and cause a snapping sensation, which some patients may confuse to be with their kneecap. On examination, when we essentially apply a lateral force, it'll make the patients feel apprehension, so it'll give them a queasy feeling or an uneasy feeling. Patellar tilt is another one where you'll see that there's a difference on the one side versus the other. The lateral patellar glide, once again, seeing if there's increased movement on the affected side. And then obviously we want to assess once again the other ligaments of the knee, such as the ACL, and take a look at the menisci for any other associated injuries. Imaging, it is helpful to get an x-ray to rule out an osteochondral defect or an associated avulsion fracture of the patella, plus or minus any kind of impaction fracture. CT scans and MRIs, we typically don't order CT scans as much for the TG-TG ratio. That is essentially very helpful from a surgical planning perspective. Typically we're using MRI now to assess the medial patellofemoral ligament and to rule out the osteochondral defects. In terms of management for the chronic and pre-existing laxity, typically recommend less restriction, smaller bracing, such like a neo-tracker or a neoprene brace, and then mobilizing very, very early. With the acute traumatic knee, which we'll see a case shortly, in those situations I recommend essentially, personally, a larger brace with hinges to provide more support, plus or minus crutches, followed by mobilizing early with activation of the quadriceps and hamstring exercises. Just because there's an acute injury typically with those acute traumatic injuries, you want to give some time for the ligament to heal without essentially repetitively stretching it. So that's why I recommend the larger brace there. If there's recurrent instability and the knee is essentially popping out on a regular basis, then obviously this is something that we want to get the orthopedic surgeons involved and set the patient up for a consultation for consideration of a medial patellofemoral ligament reconstruction, plus or minus a tibial osteotomy, and sometimes they'll do a lateral release as well at the time. This is an great example of a patellar dislocation. Okay, this is Manny Machado of the Baltimore Orioles when he was playing with the Baltimore Orioles, and this is a little bit different. The most common mechanism is essentially a direct blow to the medial aspect of the knee, driving the patella laterally and outwards. You can very occasionally, very rarely, can the kneecap dislocate medially from a blow in the opposite direction. By far and away, the outright majority are lateral dislocations. This is a different mechanism, however. What you'll see is that his toe, the medial aspect of his foot and the toes, catch the inside of the bag, and it forces his leg and tibia into external rotation. By doing that, it takes the tibial attachment of the patellar tendon and rotates that externally, and that essentially drives the patella over the trochlea. Subsequently, he ended up having surgery to reconstruct the medial patellofemoral ligament as a result of that injury. This is an example of somebody with chronic laxity in the emergency department. So this was essentially just turning around to pick up their dog. And what you can see on the left is I've done an outline initially in pen of where the kneecap lies in relation to the patellar tendon and tibial tuberosity. I've replaced that line on the image to the right with a dotted black marker line. And then you can see in the solid black marker line where the kneecap is now placed. A number of ways you can essentially, in a chronic laxity patient, it's fairly straightforward. You can essentially just extend the knee or have somebody distract the patient near the head of the bed while you extend the knee, and the kneecap will just go in. If there's further pain or apprehension, you can always give some sedation or medication, or on field you can do a local injection of some lidocaine or xylocaine into the joint to reduce some of the pain. But typically these go in very easy, as opposed to some of the traumatic ones which may require further medication. We're going to move on now to patellar tendinitis. It's also known as jumper's knee. There is still debate going on about the use of the term tendinitis versus tendinosis. Regardless of which, it is a tendinopathy with increased fluid within the tendon as a result of essentially overuse. It's typically as a result of the landing mechanism from jumping as opposed to the jumping itself, but this obviously occurs in jumping sports such as volleyball and basketball most commonly, and it can be associated with a partial tear. Obviously, the differential, once again, from an anterior knee pain are all those structures at the front of the knee, including the fat pad, anterior knee pain or patellofemoral pain syndrome, and anterior meniscal tears. These patients are typically tender over the mid portion of the patellar tendon. You can palpate from the patellar down to the tibial tuberosity. They may have a calcification within the patellar tendon. This is something that can be picked up on bedside ultrasound, as well as the thickness of the tendon compared to the other side, as well as any kind of partial tear. These are typically not associated, once again, with an effusion. These are extra-articular, so you shouldn't see a swelling within the joint. If you see a swelling in the joint, you want to be looking for other injuries. This is a clinical diagnosis, but once again, if you have the availability of bedside ultrasound, I would recommend using it in these cases. It's very easy to see the tendon's very superficial and very easy to identify, as well as assess on ultrasound. Prognosis, it's not uncommon for these to last over 6 months. And in terms of treatment modality, we recommend eccentric decline squats, as well as quadriceps and rectus femoris stretching. Shockwave is been described in literature as a added modality that can be helpful, as well as platelet-rich plasma has been used in a number of management studies. Resistant cases, you can refer to orthopedics. They can consider doing a tenotomy. Definitely 100% avoid the use of cortisone in a large patellar tendon like this. Obviously, the risk with cortisone is essentially the toxicity to the tendon and obviously a tendon rupture, which we want to avoid at all costs. With the quadriceps tendon, similarly, it's less common than the patellar tendon. Can be due to essentially repetitive lunging or squatting, such as like skiing, fencing, badminton, snowboarding. Occasionally secondary to jumping sports, but less common, and can be associated with a partial tear. You want to make sure that that extensor mechanism, once again, is intact. This is kind of the key take home here. That leads to a significant amount of dysfunction long term if we don't catch that early, so make sure that they're straight leg raise capable, there's no quad leg. They'll often be very tendon, patients with quadriceps tendinitis, very tender and very painful, with just essentially mild, flexion of the knee while they're lying prone. And as you flex the affected knee, it'll essentially stretch the quadriceps tendon and cause pain. Once again, it's a clinical diagnosis, but you can use that ultrasound. Once again, it's another very easy tendon to assess using ultrasound. Same thing as before, we want to focus on eccentric squats, quadriceps stretching, less evidence for PRP, but it has been used in shockwave. And then surgery with respect to tenotomy for resistant cases. That'd be extremely, extremely rare. Quadriceps rupture, so this is essentially a disruption of the extensor mechanism from the complete tearing of the quadriceps tendon from the muscle to the patella. Typically, it can occur spontaneously, sometimes with walking, if there's already significant amount of degeneration in the quad tendon or pre-existing calcification. But usually there's some kind of injury, so there's an unexpected fall or landing from either a jump or from a seated position, such as a chair or stool breaking. You'll typically have a significant amount of swelling above the patella, and they may in fact be tender there. This swelling is typically warm because it's associated with hemarthrosis, and there's going to be a quad leg present. So when you go to ask them to straighten their leg, they're unable to keep that leg straight with a straight leg raise. Once again, with this, you also want to check that neurovascular status, make sure everything's intact. This is a surgical urgency, so if somebody has a quad leg, this is something you want to get them into the orthopedic surgeon within a week to 2 at the most, because the longer it goes, the harder it is to essentially separate the 2 ends of the tendon tissue from all the scar tissue and then reconnect it without having to use a graft, which is not as effective. This is essentially a very commonly missed diagnosis, unfortunately, still, and a common medical legal issue as a result. So this is something to keep an eye out. And like I said, from the knee perspective, we want to make sure we do that as part of our assessment. This is a case of quadriceps rupture, so you can see a combination of calcification on the x-ray here, as well as an avulsion of the proximal patella. And then on the right, you can see a sagittal view of the MRI, where you can see the patellar fragment that is dissociated from the rest of the patella, as well as the proximal ligation of that quadriceps tendon with an effusion in between. Plica Syndrome. To be honest with you, we don't identify this very commonly in sports medicine practice. Probably not as much as it's probably occurring. There are a number of different plicas described. The commonest one would be the medial plica. There's also been described as suprapatellar, and as well as an infrapatellar plica, also known as ligamentous mucosum, and a lateral plica, which is extremely rare. These are typically no injury. Patients will describe this kind of dull ache, anterior medial and within the knee, underneath the kneecap, and they may report catching, clicking, or locking within the knee associated with pain. The differential here would be essentially all your anterior causes of knee pain, so your patellofemoral pain or anterior knee pain, hoffa fat pad impingement, your tendinitis or tendinosis of the quadripatellar tendons, osteochondral defects, anterior meniscal tears, and so on. In terms of examination, there's 2 specific tests that you can do. There's a Houston test, which is internal rotation of the leg, and then you essentially flex and extend the knee, and at around 30 to 60 degrees, the patella will pop. And if that happens, it's positive for a Plica syndrome. The second one, which is a stutter test, a patient is essentially extending the knee in a seated position, and as they flex, the patella shifts and stutters at about 45 to 70 degrees. That's positive for a plica. So once again, the knee, the patient's sitting, their knee is extended, and then they start to flex the knee. Looks like the kneecap's kind of shifting or stuttering as a result of the underlying plica. This can be clearly seen on the MRI as well as on arthroscopy, occasionally on ultrasound. This is one of the things where typically you end up, patients will be misdiagnosed as, and it's quite common as having patellofemoral pain syndrome, and then on subsequent imaging as a result of no improvement or rehabilitation, we find these. In terms of management, you can consider physio with respect to stretching out the tissues and anti-inflammatories and possibly even a cortisone injection. But if these are persistent greater than 6 months, we want to get them in to see an orthopedic surgeon. Bursas of the knee. So there's several bursas of the knee, 4 at the front, 2 on the inside, and 2 on the outside. We're going to mainly focus on the anterior bursa next, but just to let you know that there are bursas that can form between the calf and hamstring tissues, the semimembranosus and gastrocnemius, as well as in between the hamstring tendons and the MCL. And then finally, on the lateral aspect, sometimes patients with iliotibial band friction syndrome will have a bursa, not always, in that area. And there can also be a bursa forming at the location of the biceps femoris insertion into the fibula. So first we're going to start with the infrapatellar bursitis. There's actually two, one which can occur anterior to the patellar tendon and the second one below. These can happen as a result of an acute trauma to the anterior portion of the knee or as a result of repetitive kneeling. Sometimes they'll have an insidious onset. You can have obviously a number of other things that can cause anterior knee pain. They typically don't cause swelling in this area apart from a septic bursitis. That's why you also want to check to make sure there's no warmth difference between one side versus the other. If there's a concern for septic bursitis, this is something where you want to consider doing an aspiration for culture and sensitivity. The other thing here with the septic bursitis is that this can happen in athletes. It'll also not uncommonly occur in patients that have to do a lot of kneeling on job sites and have an inoculation site from a splinter or a sliver. As a clinical diagnosis, you can consider ultrasound to take a look at the bursal tissue, and generally speaking, it's conservative treatment first with protection of the area, icing, anti-inflammatories, either systemically or topically. Plus or minus aspiration, there is obviously a risk of infection about 1 in 15,000. If there's any concern for septic bursitis, obviously we recommend doing an aspiration, setting off for culture and sensitivity as well as crystallography, and then starting antibiotics if there's concern for infection. In terms of prepatellar bursitis, so this is a very easy one to see. Looks like somebody, in this particular case, but in most cases it looks like almost like there's a tennis ball in the front of the patella. It's also known as housemaid's knee as a result of repetitive kneeling. It can also happen as acute fall to the knee. You want to make sure there's no patellar fracture underneath. Other things, obviously, from an anterior knee perspective, patellar tendon and quad tendon issues, as well as tears, and also other bursitis and calcific tendinitis. So that swelling is located over the patella. It's usually quite mobile and usually not tender. Obviously, if there's any kind of warmth there, once again, you want to consider that aspiration and taking a look at culture and sensitivity. Same treatment as we talked about before with respect to the infrapatellar bursitis. This particular patient, this had been going on for 2 months when they came into the emergency department. So we just did an aspiration. We talked about the other potential treatment options, such as aspiration with cortisone. Patient opted for just aspiration. The fluid was clear, and the culture sensitivity and crystallography came back negative. And in this situation, it didn't resolve, but it's very common. It's not uncommon for these bursitis to essentially recur after aspiration. This is a suprapatellar bursitis, so this has a very distinct appearance. It almost looks like there's a knee on top of the knee. In those situations with swelling, if you take a look at this patient's right and left knee, the left knee has a large suprapatellar effusion. These can often be communicative within the joint, so it'll look like they'll also have an effusion within the joint. There's a little opening in the supralateral capsule of the knee joint. Sometimes it'll get closed off with a large suprapatellar bursitis, but often it'll stay open. You can see it on arthroscopy quite readily. Once again, very little literature on this, but it can occur as a result of repetitive kneeling, once again, or acute fall to the knee, and sometimes after lunging sports. We want to make sure this has a similar appearance to a quad tendon rupture, so make sure that extensor mechanism is intact once again. Because there's going to appear to be an effusion, once again, you want to assess that joint for any kind of intra-articular injury as well as any kind of underlying inflammatory or infectious cause. This is once again typically a clinical diagnosis, but you can use ultrasound. You can very, very, very readily see the bursal effusion on ultrasound, and if warm, once again, considering that aspiration. Treatment is the same as the other bursitis. This is once again a patient that had been ongoing for several months. We talked about options. The patient opted for just an aspiration, and we did it essentially laterally, able to drain. I think this gentleman had about 60 milliliters drained. And you can see the difference between before on the left and after on the right. Sinding-Larsen-Johansson, so this is an apophysitis. This is an overuse injury in kids, typically around the age between 7 and 11. So the growth plate is not injured. The growth plate is very flexible at this stage of growth. The injury is actually where the patellar tendon attaches and originates off the patellar apophysis. And these typically are brought on by repetitive kneeling, such as some football sports, wrestling, and it's a little bit different from the Osgood-Schlatter, which we'll talk about in a second. You can consider an x-ray. Sometimes you'll see some dissociation or widening of the distal apophysis. These typically self-resolve but may require some modified training schedule to reduce the flare-ups. Osgood-Schlatter disease, however, on the other hand, this is essentially something that is a lot more common, and it's in an older age group, so anywhere from 12 to 16 or 18, and can continue to cause problems into adulthood as well. You'll typically see adults who've played basketball or other jumping sports with very prominent tibial tuberosities if they played a lot while they were adolescents. Obviously, the differential diagnosis with these are other entities that cause pain at the front of the knee. These are very, very superficial, so generally speaking, once you palpate the tibial tuberosity, you pretty much have your diagnosis. They're typically non-tender at the patella and the patellar tendon, and once again, there should be no effusion. You want to rule out a quad leg. Once again, make sure you're not missing any kind of deficit to the extensor mechanism. You can do an x-ray here. Once again, you want to rule out, there's an error here, it says patellar avulsion. You actually want to rule out tibial tuberosity avulsion, or any kind of proximal migration of that tibial tuberosity. In terms of management, you want to modify the training schedule. This is the key in terms of older athletes, making sure that they're not training if there's pain greater than 3 out of 10. Younger athletes will typically use a scale of 1 to 3. If it's 1 out of 3, and you can tolerate, you can train, just make sure you ice afterwards and take a day off the following day. If it's 2 out of 3 or 3 out of 3, in terms of pain-wise, we don't train or compete on those days. In terms of treatments, there's a number of different things from straps, patellar tendon straps, which apply a force, a proprioceptive force, over the proximal to mid portion of the patella. Some patients find those effective, some patients can't wear them because they essentially put a lot of force in behind the knee when the patient flexes the knee. I'll focus on stretching and eccentric loading of the quadriceps as well as the rectus femoris. And these can last 12 to 18 months or even more. Like I said, they can persist into adulthood in approximately 1 in 10 patients. This is something where you may consider a referral to orthopedics if there's difficulty with essentially progression or being able to maintain a certain level of activity. Pes Anserine bursitis. So this is a bursa that is underlying the semitendinosus, gracilis, and sartorius tendons, which directly overlie the medial ligament. It's not common for patients with osteoarthritis to develop this spontaneously, and they can get quite a bit of relief with either topical anti-inflammatories, oral anti-inflammatories, or even a direct cortisone injection to that bursa. Sometimes you get it as a result of a direct injury to the area as well. It's a clinical diagnosis. It's below the joint line, and they can be quite tender compared to the other side. You can use an ultrasound and take a look under the Doppler to see if there's any kind of inflammation there. In terms of management, once again, you want to protect. Like I said, you can use anti-inflammatories or cortisone.